you everyone for coming, and I really appreciate it. And I'm really looking forward to having the opportunity to share some of my research and to really share about emancipatory practice development and how I used it for my PhD. The first thing I'd just like to share is a little bit about my background, which I know you heard a bit from Susie, but I really do feel, when I was thinking about this particular presentation, I really did feel that what occurs in our past actually forms how we think in the future. So I was actually born in Sydney, and I did my nursing as a way of staying close to my then boyfriend and now husband and IT professional, who was studying at the University of Technology as well. So I went and was educated in nursing at the University of Technology. You'll see the old building there. And I was educated in an old demountable building at Royal North Shore Hospital grounds. I actually went back there a couple of months ago, and the demountable's gone, and so is the beautiful big brown brick building as well. But it was in those early days with lecturers such as Christine Duffield and Sue Nagy and Jill White and Elizabeth Beattie that my nursing philosophy developed. Whilst I'm ashamed to admit that I actually wagged much of my theory lectures back then, my PhD has caused me to revisit my understanding of theory and how theory provides the light to our practice, enabling us to make decisions, because life and practice is complex and nuanced. I worked at Royal North Shore Hospital for a year before departing to sunny Queensland, where I've worked, as we said before, in operating theatres and in ICU and various other places. In 2017, I embarked on an EPD project. Let's just call it EPD from now on, because it'll take up too much time otherwise. Working with frontline staff to strengthen their nursing surveillance practice. It was an ambitious and challenging project, and it changed me and the group of nurses that I worked with in ways that we really couldn't have imagined. EPD actually came to me as I was discussing my ideas for my PhD. My supervisors handed me chapter 3 of the first practice development book, and I was actually hooked and commenced a lot of reading, which is what you do when you embark on these things. EPD also aligned with my values of the importance of frontline staff and how frontline staff really impact how an organisation runs. And it connected with something that my father had guided me when I got my first leadership position in nursing. And his quote was, "Always have your door open, Jax." Just for fun, as you know, and to give a little bit of context for these last two pictures, I'm a lover of animals, big and small, and still have 3 chooks, still have 2 beehives. I think one of my birds have died since we last spoke, and I still have my naughty dachshund named Fred, who's there. So I'm going to just go through a little bit about emancipatory practice development. Just to really kind of help to ground the research and ground some of the terms that I'm going to be using. As most of us would probably know, PD is a systematic and rigorous methodology, and it's underpinned by critical theory. It is a social methodology as well that really works with transforming workplace cultures by working with frontline staff. And it's a continuous process that is founded on shared values and a vision which engages practitioners at the local level. And that's the thing that really sat well with me when I was first introduced to it. It uses systematic approaches of facilitation, action learning, reflection and creativity to enable practitioners' transformation and the transformation of context. And as we know, the centre of it is developing person-centred cultures. What's the purpose of EPD? Well, it's working with frontline people and their values and beliefs to explore the deeper levels of their workplace culture and to help them develop safe and effective teams. It's using lots of collaborative methods which connect with practitioners and teams to help them to raise awareness of their practice context. And as I did further work, I started to really look at what are some of the practices that are contradictory or irrational that we do, and I found EPD sat really nicely with that. And it supports people so that they can empower themselves and understand how they can influence their situation and generate solutions for their local context. And so it's a really dynamic and liberating process of social action. And really, one of the things that kind of just stands out to me now is, why is it relevant now? Well, I think one of the things that really stands out to me about EPD is that it's working with people and not on people. And every time I think about that, I think about a lot of other research methodologies that really is about taking from people rather than finding out what's really important to them and what matters to their context. And I think also the other reason it's really relevant for me is that it's about developing safe and effective workplaces based on shared values. And the other thing that's I've really become a champion of is that EPD is actually really comfortable with complexity, and it understands that crisis is actually part of the process. And this really aligns with one of the kind of founding theorists or philosophers of this space, Brian Fay, who talks about the 3 E's: enlightenment, empowerment, and emancipation. And it's a space to be creative and innovative and generate solutions. So I'm just going to talk a little bit about the underpinning theories, just really briefly. So don't be scared, it's only going to be brief. But PD is underpinned by several important theories and critical science, social, that are really drawn from the critical worldview. Critical social science is the theoretical root of emancipatory practice development and really guides its approach. And it has its origins in critical theory, which is underpinned by 3 main assumptions: that the systems within which we work exist really because of inequality and injustice. And you'll kind of understand that as I kind of step through a bit more about my research. That these are governed by dominant ideologies that maintain this inequality, and that hegemony is where the oppressed accept the truth status of these dominant ideologies, and they accept them as working in their best interests, where actually these ideologies actually maintain their oppression. And when we start working through the practicalities of my research, you'll start to see where that was really outplayed just in the everyday practice of nursing surveillance and patient assessment. So other theories and other parts to PD is holistic facilitation, which is an enabling and supportive approach. This is enabled through a sustained relationship that uses critical reflection to raise awareness, whilst to support people their change initiatives. PD is also closely aligned with critical participatory action research, or CPAR, which is actually kind of a research approach that provides structure and form to our research. And active learning and action learning inform the workplace approaches. And finally, critical reflection is essential to PD to help participants make sense of the ways that they've been working, how they've been created, and also how these can be different. So with my research, the first kind of question is why nursing surveillance? And I want you to just think nursing surveillance is kind of a big academic word that just is about the process of continual and purposeful ongoing collection of data and interpreting patient data to support a nurse's clinical decision making. And so really, in short, it's how nurses keep patients safe. Nursing surveillance reduces, sound nursing surveillance reduces patients' risks to adverse events and failure to rescue, and impacts patient mortality. But ward culture is also closely connected to nursing surveillance capacity through staffing, education, and organisational environment. The literature also presents an important debate about nursing surveillance and the translation from theory to practice, which is really where EPD starts to come in. Nurses have the capacity to do comprehensive patient assessment through all of their undergraduate education, yet on the ward, it remains a contested area of practice. And it's really affected by how nurses understand their role and their interprofessional relationships within the multidisciplinary team. It's also impacted by de-skilling and the use of technology and the audits and efficiency agendas that are quite prevalent within healthcare. What we found in research is that what looks good in theory is not occurring in practice, with growing evidence that patient assessment is actually suboptimal on the wards. And to sum up, really, nursing surveillance research is largely focused on vital signs, debates about curriculum and who owns the core skills. So why did I choose EPD as a methodology to support this piece of research? Well, one of the things I think we all know is that the healthcare environment is a complex environment, and assessment practice happens in a really contested space. This environment is surrounded by rituals and routines, protocols and policies which actually constrain nursing practice. And in this research, we were interested in how people at the front line could influence and transform their workplace culture of assessment practice. We wanted to work with the local level of staff and help them, work with them to develop a shared understanding. We also wanted to work with making visible practices that are actually contradictory and irrational. So facilitation and active learning were really important. And we wanted to look at how this practice could, or how this kind of methodology could really support people to understand how they could influence their situation and generate their own solutions. So the research was undertaken in a neuroscience ward of a large tertiary hospital in Brisbane, and that's pretty typical of a lot of acute care settings. It consisted of 63 public and private beds and a mix of medical and surgical beds. What was really interesting with this ward was they'd recently relocated and undergone a significant expansion. We developed a collaborative partnership with the ward for 12 months before we even started. And the ward had a mixture of RNs and enrolled nurses with about 42 staff. And an important thing about ethics is the ethics process in these kinds of research is actually quite challenging. I often say to people I could have conceived and delivered a baby for the ethics process that was undertaken. This just gives a little bit of a flow on how the journey unfolded. I don't want you to think that it was really neat, even though this slide looks really neat, but we did move through a process of exploration, transformative action cycles and evaluation, but it was really this swirling journey through all of these different levels, and also then as a process of going forward. At the beginning, we did the contextual exploration where I observed nurses, observed 12 nurses for a whole shift, and then did interviews to really get a sense of what was the current nursing surveillance culture. Then I worked with the ward for a whole year with an action learning set that was a group of nurses that participated, a group of 6 nurses that met together for 2 hours every 2 weeks, developing and working on different projects. We also had workshops with the whole ward at the beginning of that year and then at the end of the year, and I also provided facilitative support embedded 1 day a week on the ward. And then finally, we worked together in evaluating by doing a final observation, similar to the contextual observation. And then we also evaluated the different initiatives that the ward worked with and brought up. So the first part of this was the contextual observation, which really shows, here you start to see those dominant ideologies and the hegemony. During that contextual observation, and you can see there published work, so you can look it up whenever you like, but here you can see that what we found was that really nursing surveillance was like a fabric that really kept patients safe, and it was really settled on these 5 different values. But that fabric was actually really vulnerable to these dominant ideologies, which tend to come from the top, such as biomedical dominance and managerialism, but also by how the nurses themselves were interacting with those dominant ideologies by marginalising their assessments, being really focused on the task or about how they communicated patients as they were deteriorating. And some really good examples were how the primary nurses kind of excluded themselves or listened from the door during consultations. Their clinical judgment was organisational agendas for discharge were prioritised over their clinical judgment or transfers, and they rationed their patient assessment activities to vital signs, and these were frequently performed by less experienced staff. So really we could start to see that the nurses were actually in their practice kind of and clinical expertise making it invisible and diminishing the importance of it to themselves and to their teams. So as part of the kind of transformative PD journey, we then used 3 different methods to raise awareness of these practices, and we did this in, the first part of it was to do some workshops with the group, with not just the group, with the whole ward. So we did 2 half-day co-facilitated workshops, and the staff were just introduced to several PD methods, and they just started to work towards their shared vision of keeping patients safe. And this was one of their posters. We did ways of working and values clarification and visioning, but one of the really most successful processes was Bruesch and Gordon's idea of nursing stories, which we used. And nurses were asked to write stories about how their assessment made a difference and then read these back to each other. And what we noted in them doing this was that they were writing themselves out of the story and giving priority to other professions for their work. So we asked them to rewrite their stories and then and asked them to centre themselves into the narrative. And this is a poster of them. This poster was printed in AO size and put in their tea room, and it became a real focus for anybody who came and worked on that ward, that they all wanted to read the stories. Here's a smaller story, and you can see here where the nurse has really brought the I back into the story. I arrived, I contacted the doctor, I felt that the patient needed further review. I called the Met call, the patient was reviewed. And so it really helped to bring to the surface and bring to the fore the importance of the nursing work that was actually being undertaken, but that the nurses were actually hiding and didn't even realise that they were hiding. And that's hegemony. Here, I'm going to step you through a couple of the transformative cycles that they did. We had that action learning set of 6 nurses, as I explained, and they moved through all of these transformative cycles, and basically together they had 3 larger ward-wide innovations and 2 smaller innovations. So let's just have a little look at a couple of their innovations. One of the ways that the group worked was they actually needed to establish a shared sense of purpose, and they needed to connect with each other. So we needed to create some psychological safety for them where they could speak up without any fear of humiliation or reprisal. This is really important because if you're going to put contradictory practices or even going to raise the topic that something you think is contradictory and put it under scrutiny, you really need to make a place where it's safe to bring that up so that the action learning set could really start to take risks and try new ways of working together and make some room for some curiosity. So that was just really essential. This process of the ALS started to really connect together, and they started to really look at different practice contradictions as they started to work with one another and work with me. One of the first big innovations was this thing called the My Met Call series. So this was their first initiative, and it really came as a seed idea from an important experience that one of the ALS members shared with the group following a difficult My Met Call episode. And this is where they were really exploring their own practice and had become an important focus for them. And they'd grown in their awareness of contradictory assessment practices which had allowed their voice to be silent. So they modelled a new way of making visible their important assessments. What happens in a MyMet call session? Well, the nurses gathered together to share a patient deterioration experience, and they used 3 questions to frame that experience. What did I notice? What did I do? And what have I found or learned since reflecting on this situation? So they were given 15 minutes to do that. And then 15 minutes is set aside for facilitated discussion from the rest of the group. So this isn't a debrief session. This was really a session about bringing to the surface the important work that nurses do at the bedside in assessment to pick up patient deterioration. And so each action learning set member brought these to the surface and shared an experience, and then they would support their colleagues to do the same. And then eventually this just became an accepted practice on their ward. And the title, that really came from when one action learning set member just proudly stated, well, they're our Met calls, Jacqui, so that's why they made the title. So I'm well aware of time, and I'm just gonna, I'm not gonna stop, but Susie, I just wanted to say, I've got about a little less than 10 minutes to go, is that right?
Yeah, we're on till 1:15, Jacqui, so we can get any questions through the chat box, but you go and we can monitor those, and we can always respond afterwards anyway. Keep going.
Sure thing. No worries. Okay, well, I'll keep going, but I will just kind of breeze through a little bit more about this because there's some really important stuff right at the end I'd like to talk about. So this is one of the quotes, which really just talks about how one of the nurses was really impacted by doing this process. So where they began to better understand the importance of their work as a nurse and how important their clinical judgment was and how they know their patient better, and that they started to realise that their voice was important and that it mattered. And I just really found that the simplicity of this innovation was just really, really impressive because it raised awareness to not just that particular nurse that was presenting, but also raised awareness of actually the hegemony that was occurring within the ward, where they were just accepting practices and not realising that actually that practice was actually hindering them by remaining invisible. So I just really enjoyed the beauty of and the simplicity of this. And this was the thing that I think really stands out for EPD. They did a second innovation. This was a second really big innovation called the shared GCS, which being a neuroscience ward, Glasgow Coma Scale is a core assessment for patients. And but this had really become a contested practice on the ward. It was done in isolation. The nurses weren't discussing the results between each other, and it had really become a breakdown in patient safety. And the nurses had really identified this very early on in the piece. So while they continued to refine their MyMet core work, they then went into this new cycle. And they really needed to find out how much did the ward understand, or how much did the nurses understand about a person's GCS. So they created a fun way to gather data, and they compiled their own short video, and then that was put on somebody's phone. And then at the end of that short video, which was just, a little role play between the two of the staff members, then they asked the question, what was this person's GCS? And everybody's staff just responded to that, popped it into I think it was a glass bowl, and then we just went through the data to see how many people actually got it correct, how many people understood the breakdown. And what we realised that was the nurses didn't really have a strong and sound understanding of what a GCS was. And so we then looked at ways to enable that understanding, and it was much more than education. It was very much about the action learning set, working side by side with the nurses, and then they decided to, as part of that process, by bringing in a shared GCS that happened at handover. And what you started to find was that education was happening right at the bedside as two nurses were discussing they were doing a shared GCS assessment at handover. So then they were discussing the GCS. But it was actually much more resisted as a practice by the ward, and the ward needed a lot more engagement with this particular one, because I think it's really started to challenge the ward, because they really felt that they had a sound understanding of this practice, and yet our evidence had kind of really demonstrated that wasn't as sound as they as it appeared. So, but this reflection just really highlights one of the RNs who are encouraging their colleague to participate in their new approach. And as you can see, the innovation was really starting to build team relationships as the nurses started to respectfully encourage their colleague. And so it was a really beautiful and innovative process where the ALS was really starting to take a risky step and try something different, really rethinking practice at the bedside and rethinking assessment practice and patient safety. We then, as a group, started to look at transforming the safety huddle. And that was because the safety huddle and this ward was taking 20 minutes. And so it was only leaving 10 minutes for bedside handover. It had become really bloated, and it was really impacting the capacity for the nurses to do their shared GCS assessment. So the Action Learning Set got together with the clinical nurses group, and they really felt that the safety huddle was having a detrimental effect. And so then they developed a new structure for the safety huddle and implemented that change, and then dropped their safety huddle from 20 minutes to 3 to 5 minutes. The staff, the frontline staff, were much happier because they were at the bedside quicker, and the shared GCS was just gaining further support and happening more at the bedside. Here you can see the next article that we wrote, which was really about this whole process that you've heard. And then the final part of the final kind of transformative process was really owning their practice change. And so this part of the journey was really where the ALS then developed their own workshop and co-facilitated their own 2-hour workshops as they prepared for me to leave. And so they then created their own session plan and a case study to really foster their new learnings about valuing their assessments. And they really started to shift their gaze from tasks to communicating for patient safety and not for protocols, and it became like a blueprint for their future. What we really found was that learning became the change. Whilst we were really looking at, practice change, actually learning is the change. And this quote, after we did our evaluation, just really stood out to me, where one of the nurses, and they weren't actually an Action Learning Set member, they were just one of the nurses being observed and interviewed at the end, and they just said, we're probably not in a position to change all the doctors' practice independently, but what we can do is change our practice and empower our staff. And I would not have had the confidence to do what I do now 12 months ago. And in the end, what you really started to see in my final observations were nurses standing at the head of the bed. They were what I call were prosecuting their cases about their patients. They weren't letting, they weren't being diminished, or they were really proud of the work that they were doing in their assessments and really arguing the case if they felt that a patient needed further review. And they weren't just happy with being fobbed off. And so they were really reclaiming their position in the team and affirming their agency. Now, I just want to step through these last couple of slides, and it is a little bit provocative, and I hope you don't mind, because I've really started to work further in the patient safety space. So there were some further insights that kind of came from this research. One of the things that was really important is about remaining true to the theory, and this comes back to my story about being a lover of theory, and perhaps if any nursing students are listening, don't wag your theory lectures like I did, because theory is the guiding light to the turbulent seas of research and clinical practice. And for me, it illuminated the direction and helped me make the decisions and moves forward. As researchers, it enables us to navigate our response to the reef and rocks of the status quo and of inertia. And I really want to just, abandoning theory would leave EPD at the mercy of a sea of methods with no lighthouse to guide it. So for me, this research demonstrates the imperative of emancipatory practice development to remain true to its emancipatory origins and be explicit about the disruptive nature of emancipation. Disconnection from its ancestry endangers it to become co-opted to serve the very agendas that it actually seeks liberation. And so we really need to look at further research to bring clarity about the facilitation approaches that raise awareness and support social action at the front line, and also how practice transformation at the front line needs meso and macro level enablement. I continue to work in the patient safety space. I continue to work with frontline staff, and I'm really looking at the connection of safety cultures and nurses' autonomy and their understanding of professionalism. But I'm also now starting to work in how patients and their families understand patient safety, and also looking at how students work in this space as well. But this last slide, I'd really like to just, as a few final thoughts, and I'm really happy to stay on, considering it was my stuff around with technology. So I'm happy to stay on and answer questions for others who want to stay. True to the critical theory way, I just want to challenge us to a couple of final thoughts. And this has just been very recent for me. How do you think about the way work is organised in your workplace? And how do you understand the status quo? Is it a mustn't grumble, or accidents do happen, or clinician behaviour must change, or we must do it ourselves? When I think about patient safety now, I, along with other preeminent researchers, think we should change our focus. Instead of practice change, and please, I'm provoking to really help us to just start looking at this a bit more deeply. Instead of practice change and then sitting back and folding our hands, remember that the status quo is a powerful beast. It requires continual work, and it does not give up with the polite knock of my good idea. As an educationalist once said, Barry McDonald once remarked, it may, however, yield to a long siege, a preemptive strike, a wooden horse, or a cunning alliance. So with this in mind, consider the current patient safety discourse. Think about some of the patient safety programs that you might have running. Think about the strong audit culture and the blame game and the latest new shiny project. Here are some of the current patient safety narratives. Patient harm is inevitable. Clinician behaviour should be the main focus for change. Organisations need to solve their own safety issues. When we shift these narratives, we collaborate across disciplines. We understand that clinicians work in systems which are inflexible and often poorly designed, and we understand that organisations need collective help to work in system-wide solutions. And finally, become aware of the significant enablement for all, both the meso and macro levels within a healthcare organisation can provide to the front line. So thank you, and any questions? I'll learn how to stop sharing. There we go. I'm really willing to ask any questions.
Oh, thank you, Jacqui. So let's have a look. We've got some. I can see a chat coming through. And feel free to come off mic if you want. There's one there off Ruth. It's been great to hear how authentic change takes time, but the process does bring understanding. It's a long siege. Crisis is part of the process. So real reinforcement of what you shared there, and thank you from, yep. Michelle. Hi, Jacqui. Helen says, thanks for the great presentation. Love your final thoughts and challenges. She's going to take those with her.
I felt a little nervous about doing that, but I just think that it's really important that we dig deeper and give ourselves opportunity to really reflect on some of these thoughts and some of the way that work is organised within our institutions, so that we can be part of that change.
The question here,
challenging the process is so important, Jacqui. I'm so glad you did that, because we do get very locked into our ways and our norms, and you know, PD is all about thinking outside the box and, you know, critically reflecting on what's working and what's not working. So best part of the whole thing.
I'm so glad to hear that, because yeah, it's become a new thing. I really encourage, if you're in the patient safety space, there's a book out there by Kathleen Sutcliffe and Robert Wears called Patient Still Not Safe, and I'd really encourage people, if they're interested in patient safety, to look at that.
Thanks, Jacqui.
There's a question up here. Did you notice any significant change in incident rates? That's a really great question, and I'm really happy to answer that right now, because one of the things that we found was that a lot of the data that's collected at hospitals, so when we talk about falls, and we talk about healthcare acquired infections and hand washing, we find that actually a lot of that's not meaningful to the frontline staff. And that was one of the things that really stood out to me, was that data isn't as meaningful to them as the data about them observing practice, them getting their own aha moments when they started to really see how they were minimalising their own practice. And then also the data that they were collecting from the MyMet call series, where they started to see nurses feeling really, their own colleagues feeling really empowered by listening to these stories and taking them away. And it was quite significant, that. So I always find it really interesting, the data that's collected, and Kim Manley will say this: is it meaningful to the frontline staff? Is it meaningful data to them?
Thanks, Jacqui. There's Chris, there's another one, there's a question there. Could you say a little more about the linkages between silence and evidence of hegemony? Can't pronounce it.
Oh, okay. That's a really good point.
Question.
Yeah. So, yeah, look, that's a really good point. One of the things that hegemony really works where, and I've been this because I've been a frontline clinician myself, where I might say something as simple as I mustn't grumble, or where I might not, where I might feel not bring to the fore the things that are really important. And so I think that when I think of my own silence, one really classic example, and I'm not sure if my supervisor's actually here today, but one classic example was when I had a serious patient safety episode happen, and I was encouraged to share it, and I said, I can't share that. What would people think, and how would they think about me, and how would they think about what happened? And this person just really said, well, if you don't share it, then nobody gets educated, nobody gets to understand what was going on. And it really helped me to understand that when we are silent, when we're silent about our assessments, when we peer behind the curtain rather than standing at the head of the bed, where we don't keep pushing, like in assessment, where we don't keep pushing and saying, no, that's not okay. We don't need to wait for another review. This patient needs intervention now. And you've got to really look at how our junior staff are impacted by power. So silence really shows that power is working, and that they are not recognizing that they have power. So it's quite a different understanding of power. And I mean, you could look up Michael or Michelle Foucault's work on the understanding of power, and that would probably help a bit more. Sorry, I saw Chris has his hand up.
Chris has got his hand up. Hi, Chris White.
Hi.
Hi, Chris.
Yeah.
Hello,
Jacqui,
Chris.
Hi, Jack. Yeah, Jimmy, as I understand it, it certainly in social science implies a powerful and a powerless. And who are the powerful in this?
Yeah.
I'm not quite clear. I mean, it doesn't do to be too pedantic, but when you're saying,
that's a good point.
When you're saying silence equals hegemony,
yeah,
where was that power coming from?
Okay, so who are the powerful? Well, that's a really good question, and you need to, if we looked at the dominant ideologies, you can say that there's a lot of power within those dominant ideologies, within the biomedical understanding of healthcare and practice. If we have a different understanding of healthcare, and not only seeing practice through that biomedical lens, then nurses themselves, because they use different forms of knowledge, they don't just use that form of knowledge, that scientific form of knowledge. They're using other things, other subtle signs that are telling them that patient is in distress. So I think that, so you can see that power is coming a lot from those dominant ideologies, whereas the silence is coming from the nurses themselves and how they understand themselves and how they see themselves fitting in it. Once you start bringing that awareness to the nurses, once they start gaining that awareness of, oh my goodness, you know, I didn't know I could stand at the head of the bed. That was one of the really significant ones for me, was observing that. You know, I didn't know I could stand at the head of the bed. I didn't know that, you know, I could, you know, that it was okay for me to really, for that particular episode, for me to really stand there and say, and keep challenging in a respectful way. This nurse was challenging the doctors, saying, no, we can't wait for infectious diseases. This patient's deteriorating now. We need to intervene now. And in fact, she actually ran down the corridor insisting for further intervention for that patient, and eventually got it. So I think that it's the powerful aren't necessarily professions. The powerful are how nurses understand those dominant ideologies, and the silence comes because they themselves are thinking that that the things that they do actually help them. The way they interact with those dominant ideologies help them, rather than seeing that there are other ways to interact with it. I hope that helps, Chris. Lost you, Chris.
Thanks, Jacqui.
No,
Thanks,
yeah, sorry, it took a while to, yeah, thank you. It feels like quite a hierarchical, traditional in the worst sense kind of atmosphere. It's
psychological
just an observation.
safety though too, isn't it, and voice, and perhaps sometimes how you've been responded to before, would keep you silent the next time, perhaps.
Absolutely, and the way that when you say it feels hierarchical, that's absolutely correct. And it was something that was, I see this culture all the time. Like, it's not just in this ward. I work in and facilitate change in other wards, and I see it all the time. And it's not until you start facilitating, like in the workshops, to really raise that awareness of, you know, start asking those enabling questions to help the nurses to start to value what they do. And part of that's the problem, is that they didn't see that their assessment practice was important. They diminished it to themselves, and they diminished it to the rest of the team. So it became diminished and less valued.
Wonderful. Well, we're at 3:24, Jacqui. We've lost a few people, obviously, because of the time, and
sure.
You have to be courageous to be a nurse. That's an absolute true statement there of Helen. Thank you. And are there plans to conduct similar research in other settings outside of the hospitals? Is a great question.
I think that's a great question. And look, I'd absolutely like to continue this kind of work. I'm continuing it in different ways and in different spaces. I'm still sitting in the acute care space at the moment, but absolutely, you know, that's the beauty of emancipatory practice development. It doesn't have to only occur in the acute care setting. And when you dive deeper into critical theory and critical social science, you start to see that it's not only in healthcare that that these systems work. It very much works in everything that we do. In fact, so, you know, it can work in aged care settings. It can work in GP practices. Really, it's just, and that's the beauty of EPD. So I guess the thing that I really wanted to just help people to understand is that EPD is a wonderful methodology to look at transforming workplace cultures, and to really start looking at how our workplace cultures are impacted by these things.
That's it. And your story was your presentation was wonderful, Jacqui. And I think a key thing that I'm sure everyone would agree was those 3 E's were so evident: the enlightenment, the empowerment we heard, and then your emancipation. Yeah, absolutely. So thank you on behalf of the 169 people that were online today. It was a wonderful learning space, and I hope everybody else found value in it. Please be generous with your evaluations. The QR is there, and I'll just move down my slide if I can to share. That's where the YouTube is for the previous masterclass series that we had in 2022, and we're building quite a playlist there, so we look forward to the next one. Yeah. And there's a few more questions, a few more comments coming in, but thank you, everyone. I'll let you all go, and we'll carry on reading this.
Thank you, everyone.
Thanks, Susie. Bye.
Thank you.